Hi everyone, this presentation is on the 45-year-old male who's been married for 15 years, 2 kids with MDDM, porn addiction, whose wife is leaving him or has left him, patient on Celexa 20 milligram. For this patient, the first thing we want to do is for the 45-year-old, we want to make sure safety assessment and stabilization is going to be one of our priority for this patient. The patient is actively suicidal with a plan and limited reasoning for living, making this a crisis that needs immediate attention. We want to make sure we are clarifying suicidal plans. We want to directly ask this patient about details of his plans, access to suicidal, to means of ways he's going to commit suicide, access to firearms, location, timing. This is because the more specific they are in their plans, the higher the risk. We also want to access suicide risk factor. We want to review non-risk factor like history of MDD, job loss, relationship loss, access to lethal means, substance use, lack of social support, and protective factor. For this patient, it's going to be his children. We also want to ensure we're collaborating with other professionals. We want to consult with our supervisors, having been there for at least 6 months. Trust me, I ask questions, and that's what I'm going to be doing. I'm not going to work alone. I will involve my supervisor in this, and being from Florida, I'm sure I'm going to have a doctor overseeing my practice that I will work as a team with. I'm going to call the hospital or the behavioral units the patient might be going to determine if the patient requires inpatient hospitalization. I will assess if the patient access the patient's means for self-harm. The other thing that is critical for this patient is to ensure patient safety. If emergency hold is necessary, given the active suicidal ideation and plan and the daily alcohol use, it might be important to initiate an emergency mental health hold. For example, in Florida, we use the Baker Act. It is important also that we are explaining to this patient why we're doing it, the importance of why we're doing it, and we want to make sure we're documenting why we're doing it. We need to document. If we don't document, it didn't happen, so we need to document. So depending on the assessment, the result of the assessment I obtained from this patient, I might advise the patient to call 911 if they don't need to be committed to the hospital. That might be possible, just depends on what I observe. If the patient does need to go to the hospital and they're refusing, I might be obligated to request an EMS to come transport the patient involuntarily if the patient is refusing to go to the emergency department. Also, as nurse practitioner, it is important we engage in therapeutic relationship. We want to be empathetic and validate the patient's pain and grief. We want to make sure we are acknowledging that we understand that what the patient is going through, that the patient is experiencing pain. We want to give the patient the opportunity to express his feelings without being judgmental. We want to explain that it's our job, it's our goal to work with the patient to ensure that they are able to transition into the community and function normally, like normal individuals in the community, safely. and the goal is to ensure the patient's safety and develop a plan that will help him get through whatever crisis they're going through. If the patient is hospitalized, following hospitalization, or if the patient is not hospitalized, we want to have a structured outpatient program that can provide the patient with additional support and therapy during his transition back into the community. We want to continue regular therapy section with focus on the issue mentioned previously. We want to continue medication management appointments to monitor compliance and see if there's any adjustments that need to be made to the patient's medication. We do want to encourage the patient to participate in support group, such as grief support group, divorce support group, and co-parenting support group. There might be other resources out there that the patients might benefit from, so we want to make sure we are providing those resources, access to those resources to the patient to be able to use those resources if they do need it. And if possible, we also want to provide the patient with CBT therapy, communicate with other therapists, and make sure they understand this patient and follow up from there. And I will attach my reference to this discussion, and that's it. Thank you very much for listening.